Welcome to Doc podcast. My name is Abbas Shafi, gastroenterologist.
And I'm Rob Hoyer, medical oncologist.
This is a podcast about lifestyle medicine, disease prevention, and longevity.
This podcast is provided for informational purposes only. It is not medical advice. Please consult your physician for individualized therapies. Please also check out our website at doc2doc.health. That's doc2doc.health. There you can leave us messages, make suggestions for future episodes, and ask us questions. And now, on to the show.
Hello, everybody. Up to now, we have talked about lifestyle medicine, such as diet, exercise, and as well as some of the complication that comes with poor diet, such as metabolic syndrome in gastroesophageal reflux disease and consequently ending to esophageal cancer, as well as poor diet with colon cancer. However, unfortunately, some of our patients will be diagnosed with some type of cancer. And talking to many of my patients, Rob, they feel like it's a whole new frontier for them. And looking through the literature, sometimes it's very difficult to sort out that they have a roadmap for the patient, how to follow. The word of cancer is a very scary thought, but of course today there's many of them can be treated or at least be controlled. So I thought it would be a great idea to, when a person that we diagnose whether with any cancer, pancreatic, colon, or esophageal cancer, and we refer to oncology departments, what are the expectations? What are the sort of roadmap? What are the things that patient can expect for this near 2-3 months, and to get to the right hand, to the right treatment, as well as releasing some of the anxiety and stress that goes with the diagnosis of cancer.
Thanks, Abbas. It's a complex process when diagnosed with a new cancer, and what I'll do is I can give a bit of an overview, and obviously this is going to vary for patient to patient. This is not going to apply to everybody. For example, some patients may need only surgery, and it may be fairly straightforward. Oftentimes, if someone is diagnosed with a cancer, we're going to be looking at the use of surgery, radiation, and possibly chemotherapy. And today I wanted to talk a little bit about the modern term for chemotherapy is actually encompasses a couple different treatments. And so I think it's important that we have that conversation about what do we mean when we say the word chemotherapy. So we'll talk about that.
That's great.
So the first thing is that chemotherapy is an older term, and traditionally it was used for a type of a medication, usually some type of a chemical. For example, a drug called cyclophosphamide or doxorubicin. These are conventional what we consider conventional chemotherapies, and these are medicines given typically intravenously, although some are given orally, and they are used to stop or slow cancer cell growth. And so they actually get into the inner workings of the cells and may stop the division of the cell, or it may stop in different ways. They may affect the copying of the DNA, the genetic material inside the cell. They may actually affect the microtubules, which is the cell structure, how the cell stays intact. They may actually stop the polymerization or the formation of these microtubules. That's with a drug called Taxol that we often use, or paclitaxel. So they're different. So they're different medicines. They all have different mechanisms. That's what we call conventional chemotherapy. These days, though, we're using less and less of these conventional chemotherapy medicines and actually using what's called targeted treatments. And these are treatments that are designed to target specific pathways in the cell. And this is since the 1980s. All these different pathways have been described. So it's kind of fascinating. Each cell is almost like a little world inside inside that cell. There's thousands of different processes and pathways and proteins, and we have the ability these days to actually inhibit a very specific protein or group of proteins in different pathways. One of the first pathways that was described was called the MAP kinase pathway, and one of the most common that we use is what's called a BRAF inhibitor. Just an example, we use that for melanoma. And this is a targeted treatment that inhibits that specific BRAF protein. And so the side effects of these medicines are completely different than what we see with the conventional chemotherapy. And the last one that you'll often hear grouped into this whole umbrella of chemotherapy is immunotherapy. And this is a totally different mechanism, actually activating the immune system to fight the cancer. And that's a whole different type of treatment. Most of these are given intravenously. Some are actually injectable. Most of them are intravenous. And these medicines activate certain cells called T cells and other cells of the immune system to fight the cancer. So there's quite a few different types of treatments available today. And within each of these categories, we now have dozens of different medicines. And so this is there's a lot going on and a lot more to come. So this is I thought it'd be helpful to give an overview of some of these. Before I start, it's very important to, if you're diagnosed with cancer, to understand what stage of cancer you have. That's really, really critical. And the stage is so critical because all the treatments are predicated on that stage. So for certain cancers that are early stage, for example, maybe only surgery is needed, or maybe it's a combination of surgery and some chemotherapy. So this is really critical. Also, it's really, really important to have a discussion with your doctor about the goals of care. What are you and your doctor trying to achieve with this treatment? That's so critical, because is the treatment, for example, is it to try to cure the cancer? Is it try to slow it down? Is it try to shrink it so that surgery can be done? There's different goals of the treatments, and so that's important.
So when I diagnose a person, say for colon cancer, and we send it to you, can you tell us about the first process when you have a conversation with the patient as the initial visit to set up this roadmap? Can you go through some of the staging, what diagnostic staging we need to do? And I don't know if we have tumor board to follow that. And can you go just simplify? So say somebody with colon cancer came in, what are the first thing you do for staging? Sure. What are the common thing that the patient should expect? Because many patients, they want to go to therapy, and I tell them it's going to take a little while to, as you mentioned, staging, preparation, understanding, both not physiologically, also emotionally, and their family get prepared for this journey, because there's going to be nutritional issues, other things. So if the patient send a consultation to you for colon cancer, what are the first visit? Can you tell us about that?
So part of this discussion will be based on when I'm seeing the patient. For example, if the patient's already had surgery, it's a little different discussion than if they have not had surgery. But say, for example, I just see a patient who has new diagnosis of colon cancer from the colonoscopy. The first thing we'll often do is do a CAT scan of the body, of the chest and abdomen, to see if there's been any spread of the cancer. And that could be spread into adjacent lymph nodes that are near the tumor. It can also be spread to the liver or lung. So that's really important. Typically, if the cancer is spread, we usually don't recommend removal of the main tumor where it started, unless the cancer is blocking the colon. And so there's a variety of decision points that we have to have discussions with the patient, and of course surgery is involved in these conversations. But a CAT scan is often is always part of the workup. Laboratory testing will often check a test called a cancer marker, or what's called the CEA for colon cancer. That's often done. Other lab tests to make sure there's adequate organ function, liver, kidney is functioning, and also just a general assessment to make sure that individual, the patient, is healthy enough to have surgery or other treatments needed. For example, chemotherapy, radiation in some cases. So that's the.
What are the team involvement? When a patient comes to your office, then after that, I know there's a team get involved, and then talk about tumor board as well. First the team? Sure.
So we have a team of, we're very fortunate in our practice. We have excellent oncology nurses, and we're very fortunate to have what's called two nurse navigators who only do gastrointestinal oncology. and they can help the patients with education. They can help with coordination of different appointments. They can help answer questions that come up in between appointments, and they're there as a resource. So that's really helpful. And a lot of times in many health systems, the patients have to go through various different departments. For example, you have to go through radiology for imaging. You may have to have a
radiation oncology
radiation visit. You may have to have if you need chemotherapy, a port, which is a device used to give chemotherapy. So all these different departments are involved, and it's often kind of a whirlwind. It's confusing because there's so many different parts of this going on. So the nurse navigator can be very useful and helpful. Also, we have a team of really excellent oncology social workers, and they are just phenomenal in terms of helping with transportation or helping to, if the patient's having questions about insurance, help with that, all sorts. So there's many different facets of this. And one of the key elements is patient engagement. So, and I highly recommend patients bring a family member or friend with them to the appointments, take notes, because there's so much information given that it
can be overwhelming.
It usually is overwhelming. And so what we try to do, just like we're talking about here, is break it into pieces so that we can move to one step at a time.
What about the tumor board? I know sometimes we get together with different subspecialty for certain cases to see what's appropriate for the patient.
This is the best treatment for a patient with cancer, is to have a tumor board discussion, and that's something that we do every week in our program. And so the doctor brings a case to the conference and presents that case, and we'll talk about the presenting symptoms. We'll talk about what the biopsy showed, what the pathology report is. We'll talk about the scans, and then talk about a plan.
Usually there is a pathologist, radiologist, some radiation oncologists, and multiple oncologists, as well as the nurse navigator, as well as social workers, right? Is that correct?
So the whole team is there, and
right.
We'll have this conversation to discuss all these different elements of the care. So it's really helpful because you can get a little bit of guidance. For example, if there's a question, should we do surgery first, or should we give chemotherapy first and then do surgery? It can be extremely helpful to have that conversation and have that,
tailored medicine or tailored treatment
customized to that patient. And then we can either call the patient or meet with the patient and follow up. And then sometimes it involves a referral. There's a recommendation, that we should have a radiation oncology referral. So we'll make that referral. Sometimes a discussion about a clinical research study. And so let's have that conversation about a research study that individual may be eligible for and may want to consider. So there's a lot of elements for this. And part of it is having a framework. And that's what we do in Tumor Board, is have that discussion. And there have been a variety of technology components to the tumor board now. So now we can do it both in person and over Zoom. And so we can do hybrid tumor boards. And it's very nice if, even if I'm out of town, I want to present a case, I can just log in and have that conversation. So the tech has really helped to facilitate these conversations. And usually about half of our doctors will participate remotely, other half are in person. And
sometimes I've seen my patient participate in those meetings too, at least pre-COVID. Is that still sometimes you guys do?
We pre-COVID, we were doing what's called the Multidisciplinary Clinic. And that has, in our program, has slowed down a little bit with COVID and some other staffing changes that we've had. But yes, the patients come in to the clinic immediately after the tumor board, and then we have a meeting where the patients can meet with the medical oncologist, surgeon, and radiation oncologist, in addition to all the other supportive care, social worker, physical therapy, dietitian, genetics counselor, and they can all meet at the same time.
I saved them lots of office visits. I know some of my patients been through there. They think that was the best thing happened. At least, everybody was there and they're straight. Sort of, there was no confusion between the doctors and nutritionists and all things. They had a very, very clear roadmap for after that meeting that understands what the goals of the treatment is.
It's a very good way to see patients, and so we very much really do encourage multidisciplinary clinics. I've had feedback that sometimes some patients think it's a little bit too much and in one day,
Sure.
and certainly that feedback. And so it may not be for everybody.
Sure.
Talk to your doctor about this, but it's something that can be very useful when you have a patient that needs to see multiple specialists. It can be very, very useful to have that meeting, and then you can also have meetings after that. It's not a one-time thing, so we can meet with the patients afterwards and have further discussion about their particular case.
The goal of the end goal. So I know if each patient is different. Can you sort of summarize, for example, cure versus, maintain or maintenance of the tumor? And I know with immune therapy has become more. So not everybody get cured, but may prolong. So a little bit of, and that's have to do with patient, the age, what's their comorbidity or more their health and other things. Can you just tell us how you approach that? And of course, is individually is tailored to that patient. So that's I think a tough decision making to do at the beginning, but at least you understand what the patients and the family what they're going to go through.
Right. This is a very much very individual discussion for each patient, but if we just talk about this in general terms, so the term cure means that our intention of the treatment is to cure the cancer. By that, we mean that 5 years elapses after diagnosis and there's no reoccurrence of the cancer, and that what we call no evidence of disease. That's a term we often use. So that is something that is possible these days for most early stage solid tumors. And so, for example, early stage colon cancer, breast cancer, prostate cancer, most early stage cancers can be
curable.
Can be cured, and usually that involves surgery for the stage 1 and 2 tumors. Stage 3 tumors oftentimes will require surgery, and sometimes will need chemotherapy depending on the specific disease. And that's why when we talk about this, when Abbas and I talk about the importance of screening, lifestyle medicine is super important, as we've discussed, but you got to know if you're having, if you have a stage 1 breast cancer, that needs to be treated. And so that's something, or early stage colon cancer, that is a
curable disease,
a very curable disease. And typically with colon cancer, you just simply remove that segment of the colon and that person is done. They don't need any further treatment. They will require follow-up colonoscopy, but that's about it. It's so this is the key, early diagnosis. For patients who have disease that is not curable, we often use the term palliative, and that means trying to slow or lessen the symptoms of the disease. And so palliative chemotherapy is used for a variety of different conditions. Typically, the cancer has spread in this setting. Usually it's what's called stage 4, meaning the cancer has spread to the liver, lung, or bone, or somewhere else in the body. And we cannot deliver a treatment that will remove all that cancer from the body. So surgery is usually not an option for those patients. We still can use radiation and chemotherapy in specific ways to treat the cancer, but the goal is to try to slow the cancer without curing it. And there are multiple studies showing that chemotherapy can be associated with improvements in quality of life and length of life. But of course, it's always important to talk with your doctor about the specific side effects of your treatment. What goals what's the goal of the treatment? What goals as a patient, what goals do you have? And is there something that you want to do, or a trip you want to take, or something you want to do? So that's really important to talk with your doctor about, because everyone's goals are different. And what kind of side effects are you willing to accept, what type of side effects can you expect with your treatment? So these are all conversations. Hard to summarize these because they're so individual, but something that definitely is important to discuss, and it's important to define, or at least have a conversation about this up front, so that when several cycles of chemotherapy elapses, several months have gone by, when this repeat scans are done, or there's next phase of the care, we can say, okay, here's where we started, here's where we are now, and then we can go from there with the next part of the treatment.
Yeah. As you know, there's certain, like breast cancer, colon cancer, it could be genetic. So, and we don't want to have more than one person in the family there. So how do you, genetic counseling, I know this is available in UC Health and other places. So how you approach that, so we prevent not only, of course, treat the patient as well, prevent from the family member. How do you approach that?
So this is very interesting because when genetic counseling first became a part of cancer diagnosis and treatment, it was oftentimes for that individual patient. But remember, what we're doing is in these situations is actually testing what's called the germline DNA. So we're testing the genetic material that is going to be passed down to descendants, and is very pertinent information for the family. So when we have these conversations, with the patient, we will discuss that this is important information for both that individual as well as their family, and recommend, the patient's not obligated to discuss this with their family, but we highly recommend that they do. And usually it's helpful to bring a family member with to the appointment to have the discussion. There's always a conversation about when to test and how to test and should we test, and that's something that each individual can decide. We do think it's very helpful and to have a genetics counseling consultation prior to the testing being completed. This way, the patient can be educated about what we're testing and why, and the results. What kind of results might we find? And so this is often helpful, and just be able to give that individual a heads up about what kind of information we're potentially going to be talking about with the results. It's gotten a little bit more complicated recently because now we do these multi-gene panels. It's not just one gene. We might do 84 or 100 or 200 genes that we're looking at now. And soon this probably will get supplanted by just whole genome sequencing, because now that is coming down to a price that rivals the cost of the genetic testings for those individual genes. So if you can check the whole genome for these conditions, then, or I should say, check the whole genome for these genetic potential conditions, then maybe just the whole genome is the way to test. As we expand our testing, the amount of genes we look at, we can find other things. So it might not just be for oncology.
Sometimes there some colon cancer associated with ovarian or breast, or at least we look for other things that potentially may in the horizon that we can prevent. I tell my patient, once you have one cancer, that's the only person hopefully in the family that we do. We can prevent by proper screening and proper genetic counseling, not only for that patient not get another cancer, and also another family member doesn't it. So if they do, appropriate screening, so there'll be more sort of, again, is like lifestyle medicine, also prevent from going through the same scenario as the patient's going through.
Absolutely. So knowledge is power, and having that ability to know that someone, for example, maybe at higher risk of colon cancer, they can have their colonoscopy at a younger age. They can, they can work on lifestyle. There's various things that can be done to be able to reduce risk. For some individuals at a risk of breast and or ovarian cancer, this can, after childbearing and breastfeeding is complete, they may elect to have breast surgery, have mastectomy, to prevent the risk of breast cancer. Same thing with ovarian cancer. Once childbearing is complete, that individual may elect to have the ovaries removed, because the risk of ovarian cancer, and if that individual has a very high risk, the risk of the surgery itself is probably pretty small, and that may prevent or lessen their risk of developing ovarian cancer. So yes, very individual discussions and conversations, but this information can be very useful for the family. And oftentimes what happens is the family is notified about this, and then they are offered testing. Some of the companies will now even test the family for free within a certain period of time, and so they can get free genetic testing for that specific gene to see if they have the affected gene. So it's very helpful. I'd just like to take a second and make a small plug for our website, doc2doc.health. There you can leave us messages, ask questions, and also leave suggestions for future episode topics. Also, if you have a moment and can drop us a review on Apple or Spotify, that will help others find the podcast in the search algorithms. Thanks.
Let's talk just a little bit, a few moments about the bone marrow transplant and how we can register to be a bone marrow donor. I know people with myeloma, other things, some of my patients, some of my friends, they went through that and to get appropriate matching. So maybe just, I think the more pool do we have, the more cure for our patient is like liver transplant or kidney transplant. So how can we, I know in our dry says, you want to do a organ donor, but for the bone marrow is not as well known, and I think all of us can be a little help to help another human being. So can you elaborate a little bit of that? And I know that's a lot more in depth and thing, but maybe some people are not aware of it and they like to be is as simple as giving blood. Is that correct? So this goes back to a little bit of my prior life or younger life. When I was in college, I worked at a lab that did sequencing of the HLA types. And so it does get a little technical, but I can certainly provide an overview of that. So how this works, and it's if you just have you can show it with a tissue graft in a mouse. If you just happen to take a mouse and take a little piece of skin and put that skin onto the skin if you graft it into another mouse, with almost certainty that graft will die, because there are these antigens in the tissue that are different than the antigens on that mouse's immune system cells. And so we call this it's called the major histocompatibility complex, and there's class 1 and class 2 and other proteins. But basically that allows our immune system to determine self from non-self. And when the immune system sees something that's not self, it is a very, very strong reaction. And this is why with you can demonstrate it. It's not with blood types, similar type of discussion. It's not, that's a different proteins than the major histocompatibility complex, but you have to have the right blood type. And the same type of discussion, same analogy. If you do an organ transplant or a bone marrow transplant, it's best that the two individuals, the donor and the recipient, be matched as close as possible. And that sometimes can be curative, or not curative, at least prolong the life of some of the people with leukemia or myeloma. Oh, it can be curative. Yes, It can be curative for many of the leukemias, for multiple myeloma as well. And there's these treatments are very, very important in terms of the treatment, especially when patients their cancer progresses through the standard treatments. A bone marrow transplant can be very helpful. There's two different types of bone marrow transplant. There's the autologous, when you're giving bone marrow back to yourself, and those are more straightforward. In these, the patient gives bone marrow, or what we now do is actually collect stem cells, so we don't have to collect bone marrow anymore. It's actually a little easier. We collect stem cells from the blood and then can freeze those. The patient gets high-dose chemotherapy, and then once they're done with the treatment, they get reinfused just with a regular intravenous line. They receive their stem cells back, and those stem cells, by ways we don't fully understand, find their home back in the bone marrow, and they regrow the bone marrow for that individual. The bone marrow transplant from a different person is called an allogeneic bone marrow, and it can be related, a family member. The best is actually a sibling. A sibling is going to have the closest HLA type match. And
a sibling will be usually the preferred donor. We can also do donations from umbilical cords. An adult can receive 2 different umbilical cords that are matched to that individual. The matching is not as important there because those umbilical stem cells are more tolerant. They can actually, they don't have to be matched quite as well. It's kind of interesting. And then there's also matching from an unrelated donor. And so there is a registry for those unrelated donors through the National Marrow Donor Program in the U.S. And we need minorities for this. This is so crucial. So if a minority person is ill and needs a bone marrow transplant, there's a much lower chance of finding a match through the National Marrow Donor Program, just because there's fewer minorities in that program. And so I encourage everyone to go on to the NMDP, or National Marrow Donor Program. I'm a member of that. And all it is, you give a blood sample or a saliva swab, and they do your HLA typing, and then it gets recorded in there, and then all that information is secure and private. If in the event that someone with your HLA type needs a transplant, they'll call you up and ask if you can be a donor. And these days, it's actually very easy to donate via the stem cells. We just give some.
It's just like a blood draw.
We give some medicine to boost up the white blood cells, and then use a pheresis machine to remove those stem cells. Mm-hmm. It's very safe. This is used routinely for donation of platelets, which are the cells that clot the blood. And so, this is a common procedure we do. And those individuals that we're collecting stem cells they have not received chemotherapy. They're healthy. So we can collect lots of stem cells, put them in the freezer, and then have them ready to go when the patient needs them. So it's a life-saving procedure, and it's a hugely life-changing for that individual receiving the transplant. Once they get the transplant, there is this condition called graft versus host disease, where the new bone marrow can attack the body because it sees that as somewhat different because it is. And so we give medicine called immune suppressive to suppress that, so the patient does not develop the rejection of the
body that in the host.
Right. So in this case, the graft is attacking the body. The body. Yeah.
Well, the thing is, for the donor, is really not much hassle, stuff like that. It's very easy thing, but this really could be curative for many individuals. So particularly, we are such a multi-gene culture, stuff like that is very, very important. I think the more people they register, I think the more can help another human and prevent. Because I have 2-3 friends that end up having with multiple myeloma and end up transplant, and that's one of the biggest thing to find an appropriate matching. So I highly recommend everybody that, as you kind enough to put on your driver's license for organ donor, do this, and you may one day just be able to save another human.
It's a huge gift, and it is. I get the updates, newsletters from the National Marrow Donor Program. Sometimes 5 or 10 years after the transplant, they allow the donor and the recipient to meet, and this is all done in a very controlled manner. Of course, the donor and the recipient are asked if they want to do this. Yeah. This is not done automatically. Typically, it's all done anonymously. Mm. But if 5 years or 10 years has elapsed, they can meet, and it's a very emotional gathering when that happens.
Yeah, well, it's great to always do help another person survive. So Rob, this was a great conversation. I learned a lot from it, and I'm sure our patient or our listeners would appreciate that because knowing a roadmap, and as confusing it is, and no matter what you do, you're going to be confusing, but it's good to know there is behind the decision making, there is a lot of intelligence and lots of things, and patience was that conversation that to them and their family make the decision what route they would like to take. That I learned a lot. Thank you very much. Greatly appreciate it.
Absolutely. And I just want to make one other comment. There's one member of the team that I wanted to mention, which is a huge part of this, is the oncology pharmacist. And not all practices have this. It might in some practices they will use, nurses are going to do the education about a particular chemotherapy or a treatment regimen. But if you have access to an oncology pharmacist, I highly recommend taking advantage of this person, because what they'll do is they'll meet with you before your treatment and talk about the side effects, what to expect. What is an expected side effect? What is an unexpected side effect? It's very important that you know how to identify these side effects and who to call and when. So that's something that we, in our practice, we do before every patient starts treatment. We have a conversation about side effects. And I use the example, well,
it's not only the side effect of the medicine, also what the currently medication they're on.
Yes.
And as well as herbal medicine or supplement they take. So
Yep. So yes. There's a review that we do to go over what medicines the individual's on, how this cancer treatment medication will affect or interact with the medications that they're taking, and also if the person's taking any supplements or herbals. It's extremely important. Please, please, please ask your doctor about supplements. If you're taking any or thinking of taking it, do ask about this, because these medicines can interact positively and negatively with the treatment. For example, they can actually, some medicines like St. John's wort is a common example, can actually lower the amount of drug in your system. So you may not have side effects from the chemotherapy, but it's because you're getting a sub-therapeutic or a lower dose of the medicine. It's really important that you talk to your doctor about this.
And today there's so much on the internet, they think a lot of this curative herbal therapy, which if they take without being open about it and then interfere with, yes. I know we've seen liver transplant, they can, liver transplant is rejecting, then you find out, they're taking this herbal supplement, came from either Taiwan or some other thing, or other countries that somebody went to visit. They said, well, this will cure all your things. And then you find out all this failure of the whole organ is because of just a simple tea or simple over-the-counter herbal remedy.
Yes, natural products are not automatically safe. That is a very important statement. So natural products are not automatically safe. So it's important to note that a lot of our common medicines that we use today are derived from natural products. And so taking something can have, especially as you get to higher doses, can have just side effects from that drug itself, but also can interact with other medicines you're taking as well as the cancer treatment. So it's really important.
It is okay for them to take as long as they're open about it. So, and the pharmacist knows about it, whether they can have effect. I think I think all the confusion comes, and they want to hide it. Not everybody. Some people they think that maybe it's quote not accepting modern medicine. It's just understanding that this is like a concert. They have to be work together to cure or maintain the disease, and that's when that concert interact, then the whole thing falls apart or cause more side effect.
Yeah, I think that's a fair statement, that some individuals may be concerned about mentioning this to their doctor because they're not sure what the doctor is going to say. Mm-hmm. Sometimes they'll often mention it to our nurses and pharmacists, and I'll learn about it after. And it's so helpful to know about, because then we can say, for example, well, maybe it's okay to take this medicine during part A of your treatment, but part B would not recommend. So really important. These medicines, these herbals and supplements, can have all sorts of interactions, side effects, and can really heavily impact the results of the treatment. Even some things, for example, even a simple folic acid supplement, if we give an oral chemotherapy called capecitabine, can greatly worsen hand-foot syndrome, which is a rash on the hands and feet. So this is important to talk with your doctor about literally everything you're taking. This is so critical. The other thing I want to just mention is that, especially with these newer medicines, the targeted treatments and the immunotherapies that we talked about at the beginning, it's really important to report any of the side effects and just have some understanding about what could happen. For example, if a patient is on immunotherapy, that's a medicine to activate the immune system, they have diarrhea, the first thing that we would think about if that person's on immunotherapy is to give prednisone, which is a steroid, because that person probably has colitis related to the immunotherapy. It's not common to treat diarrhea with prednisone apart from this scenario, but this is the discussion that we have with patients, and educating about these side effects is so critical. Another situation, a cough that can happen with, say the person's getting immunotherapy, the cough, that individual may think, oh, they have allergies or bronchitis or whatnot. They go see their primary doctor, they get antibiotics, the cough persists and maybe get worse. Well, it could be pneumonitis, which is inflammation of the lung related to the immunotherapy. And so it's really important to let your oncologist know about symptoms that could be side effects of these therapies. And this is something that we encountered quite a bit when we first started using immune treatments about 7 or 8 years ago. These became more and more common, and we saw a lot of situations where patients would go into the ER and have an immune-related side effect, but it wasn't recognized because none of the primary care or the ER doctors knew about these medications. And so we started doing a lot of education with the emergency room and primary care. And the key is we just need to know. So we ask patients, please call us if you're having symptoms, because it might be a side effect of the immune treatment or the other targeted therapy you're getting. The other thing is that we're now combining these medicines together. So we're giving combinations of immune treatment and targeted therapy. We're giving combinations of chemotherapy and immune treatment. So it's really important the patient knows what they're getting. And that's something that, there's always literature available about the medication, a summary that's given, a packet given to each person when they're starting on treatment. That's really important to read over that information, but also just ask questions and stay engaged.
Yeah, we don't want to scare the patient, but at the same time, we want to know that they are a part of the communication and the treatment. And luckily, it is certain, treatment for, as my mother says, we have the disease and we have the cure. We just have to make sure that the cure is appropriate for each individual, and each individual doesn't know there is a way out. And the more they know, the more they communicate, the better is the outcome.
Totally agree. That's one of the things that I do every day, and probably the most frequent thing I do is personalize this treatment to each individual. So, for example, maybe 60 milligrams of this drug is perfect for patient A, but patient B, maybe 40 milligrams is the maximum dose. Yeah. And those two individuals are similar weight. They have similar health, but for whatever reason, and it could be due to different metabolism of the medicines or different medicines they're on, that we don't know about all these interactions that happen, but it's so critical. So I usually encourage patients, if you're starting a new medication, to have an appointment with your doctor a week out is usually a good time to just go in and we often do these quick telehealth visits just over the video. How are you doing? What side effects are you having? And those are very helpful. And our nurses try to call patients about a week after starting treatments just to ask if they have any questions or concerns. And so it's a team effort. And but as we're getting more and more medicines, and throughout the mid 2020s into early 2030s, right now we're living in this tidal wave of new oncology treatments. It's getting bigger by the week. We're getting more and more medicines, more targeted therapy, yes, and now even new forms of treatment we didn't even cover today. We can probably talk about that in an episode about the new the chimeric T cells, the new T cell treatments called CAR T. We can probably do an episode on that at some point. And so this tidal wave is growing, and by the mid to late 2020s into 2030s, we'll likely have hundreds of different medications and different types of treatments for cancer, and it's beginning to be so complicated. I personally think every practice will need a pharmacist in their practice in some way, either via telehealth or preferably in person, but that will need to be part of the the oncology team, because there's so much information these days.
Well, hopefully you never have any cancer, and hopefully none of your family member. But if you do, hopefully this podcast will help you sort of roadmap. At least know it's not as easy as some people they think. So the communication is very important, and wish you the best health for everybody.
Thanks, everybody.